Welcome to Velo Unlocked, the podcast for baseball players that want to play at the next level. In this episode, we are joined by Dr. Brandon Erickson. Dr. Erickson is a board-certified, fellowship-trained orthopedic surgeon specializing in sports-related injuries of the shoulder, elbow, and knee. He completed his residency in orthopedic surgery at Rush University Medical Center in Chicago, Illinois, followed by a sports medicine fellowship at the Hospital for Special Surgery in New York, New York. During his fellowship, Dr. Erickson served as one of the assistant team physicians for the New York Mets. Dr. Erickson is a New Jersey native and played football for the University of Notre Dame as a wide receiver. His research efforts focus on shoulder, knee, and elbow conditions, especially those affecting the throwing athlete. Through his work with Major League Baseball, he has been able to better define injury patterns and treatment outcomes in elite-level overhead athletes. Dr. Erickson currently serves as one of the assistant team physicians for the Philadelphia Phillies and serves on the advisory committee for MLB Pitchsmart. In addition, he has been named one of Castle Connolly's top doctors.
All right, Dr. Erickson, thank you so much for joining us today. I know this is bright and early. In case anybody's wondering, we are filming this at 6 a.m. because the man has to get to the office.
Well, I appreciate you guys having me, and thank you for accommodating the early morning schedule.
Oh, yeah, of course. I'm up. Ken's a little mad at us, but that's all right. So let's start off with some just, obviously whenever we're doing one of these, I like to look into people ahead of time, just see if I can find anything that maybe, we don't know. Obviously, we have a relationship that's extended from beyond professional now. We're friends and everything like that. But I was still astounded to learn that cited, well, first off, 234 publications, which is peer-reviewed publications. In case anybody's wondering, that means that those are written off of a research study. Typically, those take anywhere from a year to 3 years to even get done, let alone then written. And then on top of that, cited 5,130 times in other people's research, and across all boards of research, meaning any topic out there, you are 97% more interesting than everybody else. Congrats on that.
I appreciate that. It's like the most interesting man in the world thing, except I think probably maybe our viewership would find our research interesting. Probably not everyone would find it so interesting.
Yeah. Hey, man, those were some like ridiculous stats. And not to mention, you are still young, too. We are not talking to an individual who is 55 years old. Not that 55 is old, but that, it is older. So talk to me a little bit about, extending from this. Obviously, that takes a deep burning passion to get to something like that, right? That doesn't happen by accident. That's not something that's like, oh yeah, I'm just continuing my trends from schooling in order to get here. So what causes you to have that burn to do something like that?
It's interesting, the research part of it, some people do a lot of it, some people don't do much. When I was a medical student, I think I had one publication coming out into residency. When I was applying for residency, I had a couple of people ask me, how come you don't have any more research? I said, gosh, maybe I need to do a little more research. So I went into residency and had a couple of really great mentors, some shoulder and elbow and sports surgeons out in Chicago. And they were really big into research, and they were doing it not to put their name out there, but they were doing it to answer questions, right? They were operating, question came up in the OR. They said, what's the right answer to this? And you look in the research and it's not there. So then you got to design a study and do it to answer the question. And the more questions that you have and the more research you do, the more questions that pop up. You've seen that. The more you figure out, the more you realize you have no idea what you're doing. You have to continue to work harder to figure out what the right answer is and at least have it backed in data and not just backed in somebody's opinion. Yeah. So we started that back in 2012 and then just kind of continued to go and questions continue to pop up. So you're right. It's a tough thing. It's a lot of time that's out of work, right? Because you don't do research during the day. Research happens on nights and weekends when the kids are asleep and things. But it's been really good the last few years to be able to answer some questions that have come up and be able to explain to people, how people tear their UCL, when they get back, other issues, how fast they recover. So it's helpful for me in my practice.
What's amazing too is it doesn't make you any money.
No. Makes zero.
So,
$0.
Like you're talking even further, but the problem solution thing is so incredible. And I think you see that across the board in any profession where you're going to see somebody who's great at what they do. They're just burning desires to answer questions and solve these problems. And I think the coolest part about that, and something we indicate all the time when sifting for a solution, even in a kid's training, right? We're going to ultimately create more problems because we're going to find a solution to something, or we're going to unearth something that we didn't think was the case, right? And ultimately at the end of the day, now you're left with a new board and you're like, well, shit, I got to either make a change or, hey, this, advocated for what we were doing. But so let's backtrack a little bit and let's talk about why'd you get into this field? Why orthopedics?
Yeah. It's funny when I was in high school, I went to a kind of a nerdy, medically oriented high school. People thought they may want to be a doctor, right? It's a place called the Academy of Allied Health and Science. It's in New Jersey. And it kind of sets you up for if you want to go into the medical field. You do some anatomy, physiology classes. I was an EMT, stuff like that growing up. And I shadowed a cardiac surgeon when I was in high school. Not that was the coolest thing ever, like open heart surgery, really fun. Went into medical school, did some really cool ear, nose, and throat surgery, like cancer surgery on the mouth and things. I thought that was really interesting. And then kind of got into the orthopedic field, and I met a lot of people that were kind of like me, right? So, former athletes, whether or not we were good or bad, but former athletes had a team mentality and took care of patients that wanted to get better. And it brought me back to one of, my own experiences with a doctor when I was in college, my junior year. I broke my ankle just before our opening game my junior year, so I missed my junior season, but had a kind of bad open fracture dislocation. Bone was sticking out, legs spun around, like wasn't great.
Me.
But yeah, it was pretty awesome. And so within an hour or so, they had me in the hospital in the operating room. Our team doc, basically fixed my ankle. I was out of the hospital, a few hours later and, was back to playing 8 weeks afterwards. And so that was pretty impactful for my life. And I wanted to be able to do that to other people to try to help them out. Because listen, the reality of sports is you get injured, right? It happens. You've played sports. You have a shoulder that's not great. I've played sports. I got an ankle that's not great. Broken collarbone, stuff like that. It is what it is. It's part of the game. But if you can get people back to doing what they want to do after their injury, that's the best thing to me.
Yeah, it's amazing. And we've had some other topics here over the past couple weeks and been speaking with people, and there's this resounding element that always pops up, and it seems like everybody's chasing against, or rather trying to utilize best, which is time. And you just indicated how you felt that period of time where you were removed from your sport, your identity is shifted, and I think it's very difficult to have passion about things like that if you haven't experienced them and felt what it feels like to lose a part of yourself. And then, the idea there that, wow, I could actually help somebody not have to feel this, or at least get them to understand that I'm empathetic to what they're going through.
Yeah, the empathy part's a big part because, I have patients come in sometimes, or, athletes, and they come in, they see me, they tore their ACL. They saw somebody else and they're not dismissive of the fact that they're going to miss some time, but they don't really get it. And when I explain to them, listen, I get it. I've been through it. The goal is to get you back for next season. We'll get you back. You'll get there. It's going to suck for the next 6 months and you're going to hate it, but you're going to get through it and you're going to be fine. And it's an interesting thing to show people. And I always show them my scar on my leg, show them the screws on a plate through my ankle. Like I said, listen, I've done this. I get what it's like. We'll get you there. And so it's always helpful for me to be able to do that, I think.
Yeah, it is incredible when you can take yourself, provide sort of this visual empathy as well, right? And this sort of get them to understand I've been through these trenches. Speaking of getting them through it, the surgery is one part, right? And that's a vastly important part. And I know what's really cool is a lot of times your research extends well beyond obviously the surgery, right? We're not talking about research here that's just this maneuver is better over that maneuver and holding, because obviously the rehabilitation aspect is so massively crucial to you having positive outcomes. Where do you see research lending? Because so we're in a surgery now, we're in a rehabilitation state after the surgery. Where do you see research lending towards reshaping sort of that sort of continuum, right? Yeah. Where we can get proactive ahead of that surgery.
I mean, so if you're talking about, let's start with surgery moving forward, right? So first of all, you gotta do the surgery right? Because if you don't do the surgery well, if you botch what you do in the operating room, somebody's not going to do well, right? It's just not going to work out. And so you got to make sure your attention to detail is there, and you got to make sure that you're using good techniques. And some of our research, like you said, has been on what the right technique to do a certain part of the procedure is, right? But to your point, that's only a small part of it, right? So I always tell patients, like, I do my part, right? My part's the surgery. And now it's your job going forward with who's going to rehab you to get you back, right? So let's take an ACL, for example, right? An ACL surgery takes me 45 minutes. We put the graft in the right place. They're done with the surgery. Everything goes great. They go to the recovery room. They wake up. The next day, they start physical therapy, right? And it's physical therapy and then strength training and everything else that's going to get them back to play. It's not my surgery that's going to get them back to play. My surgery is going to set them up for success to be able to get back to play. But if they don't put the work in going forward, they're not going to be able to do that. So some of the research we've done is looked at, okay, what are deficiencies in certain things? So within ACL tears, right? What deficiencies do you have in the leg? What do we have to correct to be able to get people back to play? So they have, different quality movement assessments, functional movement assessments we put people through now to know if they're at risk for re-tearing their ACL going back, right? Because that's a devastating complication. We talk about the elbow. Talk about, okay, what are metrics we have to have guys hit to be able to get back to throw at the same level they were throwing at before? How do we set them up for success and minimize injury risk going forward for those guys? But to your point of the proactive part, right? How do we not even get to me or get to the surgery part? That's really the key to what we've been trying to do recently and from a research perspective. So a lot of what we do is try to, one, identify risk factors for injury, right? So there's modifiable and there's non-modifiable risk factors, right? So there are some things, guys' height, weight, etc., though you can't change those, right? That's what a guy is. That's how he's built or she's built. So it doesn't matter what you do, you can't change that. But there's other things you can change to try to help decrease injury. So let's talk about the elbow, for example, right? We know that if your total arc of motion in your shoulder is decreased, you're at risk for injury. We know that if your hip rotation, your internal rotation on your landing leg is decreased, that's a risk for injury. We know if you have poor scapular control, that's a risk for injury. So those things that we can change, we want to change because we want to do our best to just take that injury risk back as much as we can. We're never going to get it to zero. The reality is sports, people are going to get hurt. But if we can just decrease that injury risk little by little and modify the risk factors that we can change, that's the goal.
There was so much to unpack there. The first thing that I will say about unpacking that is I love the portion there where you're forcing the patient to take ownership. And frankly, if we took some ownership prior to that injury, we might have been able to prevent it. But I don't want to sound like a callous person that believes that everything is their fault. I do agree that injuries will occur, right? Especially when we're pushing the limits of performance, right? And, diving in a little bit there towards the latter part of what you were just discussing, right? And talking about the fact that like total arc, is a big part and the front leg being a large part. And what I think people need to understand is these are, as they come out of research, right, these are averages, right? And the danger with averages is driving everybody towards those averages and assuming that everything will be perfect, right? But on the flip side of that, probably hovering somewhere in those means, as long as you understand the non-modifiable characteristics, and making sure that you're not shoving somebody into an area that they don't need to be shoved into. Naturally, as we throw, right, we lose internal rotation across the season. We obviously, some athletes start to gain external rotation as that season goes on in that shoulder. And then obviously the front side hip, what I think is so intriguing about that, right, is we're cutting down internal rotation or saying that internal rotation is lacking in some guys. And I think, and I don't know what you found, but I know in most of the research that I've read and even in some of yours that the resulting rotation that has to occur out of the torso just to make up that sort of fluid energy transfer because of the lacking internal rotation likely leads to most of the issues going on at that elbow. Obviously I'm saying likely, so that's very subjective, but so let's talk about then, you also mentioned in there some characteristics of making sure that an athlete is returning to sport and, some of the parameters that they need to hit prior to doing that. What would you say is, I don't know, like let's say 3 to 5 of your most impactful sort of studies that you have found that you think like, listen, this can really trend us in this direction?
Yeah, I'll tell you, the first study that I think is probably pretty impactful or set us up for a lot of questions going forward, right? When I was a resident, one of the
what a great way to put that, by the way.
What'd you say?
Well, it doesn't necessarily need to solve right now, right?
It
needs
didn't
to create
solve.
more questions.
It created a lot more questions, right? So it was back in 2012, and this was kind of when UCL injuries were starting to creep up a little bit, and we were starting to realize it.
Well, it's the same time that performance started to creep up. It's the same time that data started to creep up.
Fastball velocity goes up. Like everything's kind of related, right? So it's not a one-off thing. But so I had an attending that told me, he's like, listen, you want to focus on one subject. You want to learn everything about that subject, because then you'll be able to answer questions better, et cetera. So we started seeing more UCL injuries. When I was a resident, we took care of the White Sox. I was like, all right, well, maybe we should start looking at UCL injuries. You know, what's the trend like? Because we didn't know up to this point. It's like, all right, so we did a study. We looked at basically trends in UCL injuries in Major League Baseball, right? And we saw a huge increasing trend in Major League Baseball over the subsequent 5 to 7 years. It was going up dramatically and has continued to gone up since then. But that was the first study that started to spark this UCL madness research, right? That was the first thing that came out. And that was, 10 years ago now, right? It's been a while. But that was the first thing that started my path down the UCL world. And then also, I think, sparked a lot of other people to start to get involved with it, which was pretty cool. And then we did a follow-up study of that, looking at risk factor or UCL tears in adolescents, right? Because everybody focuses on professional pitchers, right? Because that's really cool and fun to talk about. But the reality is that's a very small portion of who gets UCL injuries and who gets injured, right?
Sure.
So we did a study looking at youth players that got UCL tears, and we saw kind of a 10% increase year over year in the number of players that were getting UCL tears and having UCL surgery. So that really started to spark the idea of, okay, this is a problem, right? So we haven't identified anything else other than the fact that this is a problem, okay? All right, so that's step one, is identifying the problem. Step one's done. Then step two is, okay, what are the risk factors for the problem, right? So we started to do a few studies looking at risk factors for the problem. So one of the studies we looked at was putting guys through a kind of a simulated game and seeing if there were some kinematic parameters. So elbow flexion angle, ball release, max knee flexion height, things like that, things that happen during the pitching cycle that we could identify as a risk factor for players and say, okay, you're specific to you, your knee flexion height is starting to go down during the game. We should pull you out of the game to potentially prevent an injury from happening, right? So we took these kids, put them through this kind of throwing progression and simulated game. And unfortunately, we didn't find anything that actually was a modifiable risk factor in that, except for the fact that their hip to shoulder separation started to change significantly from the first inning to the sixth inning.
Go down.
Yeah, exactly. So they started to,
I think that needs to be said though, aloud again, real quick. There was no modifiable differences.
Correct. In their elbow flexion angle, knee flexion.
Right. So mechanics didn't break down tremendously.
Correct. Outside of hip to shoulder separation, right? So to people listening, to give you kind of a visual, what we're talking about is when a pitcher's throwing, let's say a right-handed pitcher's throwing, and their front foot hits the ground. So we call that front foot contact. The minute their foot hits the ground, usually their pelvis is pointing towards home plate, but their shoulders are pointing towards third base. As the hip to shoulder separation starts to change throughout the game, when their foot hits the ground during the same point in their pitching cycle and their pelvis is pointing home, their shoulders are now pointing towards the third baseline, right? So now they have to get that rotation to generate, enough force to throw a pitch from their shoulder, from their elbow, and potentially stress things down the road. We didn't look at injury risk in this study. We were just looking at changes as guys got fatigued. Cool. So that was the change that we started to see. The other study that was pretty relevant and has probably been cited more than any other is the fact that the harder guys throw, the more likely they are to have a UCL tear, right? And this gets to the point of the fact that it's a sport, people are going to get injured, because when you throw 97 to 100 miles an hour, you're putting more stress on that ligament than it was made to withstand. Sure. And so at some point, you have a much higher risk of tearing that ligament. So we did a study with a guy, Pete Chalmers, who's one of my colleagues, who's excellent, he's out in Utah. And we basically graphed out all the guys that had UCL tears and how fast they throw. And what you see is basically a straight line up. For the faster you throw, the higher your risk of having a UCL tear is. And it's such a simple study, but it's so impactful to tell people, listen, you're a high velocity person. We need to work on all these other modifiable risk factors because your risk for injury is so much higher than somebody throws 75.
I love it. I love it. I love it. And this is something we talk about all the time. What people do not understand is the quest for throwing over, let's even say 85 miles an hour, right? The quest for throwing over 85 miles an hour, finally cracking that 90 miles an hour is a massive responsibility. If you do not comprehend the fact that the guy you were that was throwing 82 is not the same person you are throwing 92, then you have totally missed the boat. A representation that I gave to a kid the other day, he last season sat, consistently, I would say his floor was like 84, right? And, then this year, his floor has now been, 89. So we got 5 miles an hour.
Big difference.
Yeah, 5 miles an hour. Let's say it's 1 Newton meter even of torque at the elbow difference. It's probably not. It's probably significantly more per mile an hour, right? So now you're talking about 5 Newton meters every throw. High school baseball season, minimum 600. For a starter, that's your number one. 600 pitches, minimum, right? High school baseball season. Factor in bullpens. Factor in other throwing.
Hidden pitches.
Right. Now you're at 1,000.
Easily.
Right? So it's 5 Newton meters every pitch. That's 5,000 that's 50,000 Newton meters extra on that elbow just in a 3-month window. Now he's going to go play all summer. And you think that your training or anything is going to be the same as it was? It's crazy to me. And I don't think people appreciate the responsibility of throwing hard. And that was an unbelievable point there that you just brought up in that study. How have these studies, or how do you view now a lot of these studies shaping the way we need to look at, let's say, even training?
Yeah. I think it's a matter of, I really like how you kind of said it. They need to understand that they have a risk factor for injury, right? So by the time they get to my office, something's already happened, right? They don't get to me preventatively, right? Now, a lot of times they get to me with minor things, right, that we can take care of. And you and I working together, oftentimes we'll fix that. And part of what I do in the office is explain to them, like, listen, you throw hard. I always take them through a quick shoulder exam, a quick knee exam, quick hip exam if they're going to come in for an elbow problem, because I want to show them on the table, and generally their parents, they're with them, like, look, this is a problem. This is a really quick thing that we can fix to decrease your risk of injury going forward. And even if you came in and popped your ligament and I had to fix it, we still need to fix those problems, because if we don't fix those problems down the road, even though I gave you a new ligament, it's still not going to work, because you're still going to stress that more than it's supposed to be stressed. The ligament at the elbow goes to failure basically every time you throw. And the harder you throw, the closer it gets to failure. So you just have to keep that in the back of your mind when you're throwing. Not that this should scare anybody, because it's not meant to scare you. This is just meant to say, listen, you're at risk for injury. How do we make it so that you're not going to get injured? And that's where you come into play most of the time, and you've done a great job of doing that. And we've had a lot of conversations about it, of how can you set these guys up for success, not only to increase their velocity, but also to mitigate their injury risk as their velocity goes up.
Yeah, and I think one of the biggest issues to that parameter is we can do everything we want correctly in the off season, and we can make everything we're doing science-based. And if the athlete doesn't take ownership of the fact that that must continue in the time you are competing, not just in the time you are training, and in our training scenarios, on high level throwing, maybe the max they're getting is 40, 50 attempts before they're heading off to their season, like in one single bout. So like 40 to 50 pitches. To then go out and throw 100 pitches within 3 weeks of that, and not think there's going to be adaptation ramifications, recovery ramifications, right? Because at the end of the day, I mean, think about it, right? And correct me if I'm wrong, but the UCL, let's say a strain, right, is just simply the body's adaptation or signaling that the recovery process or your capacity to sustain that type of force was not adequate at that time.
Yeah, it's interesting, because there can be a buildup of some chronic stuff that happens, right, over time. Or there can be an acute pop.
Sure.
Right? And most of them are actually, even though people think it's an acute pop, it's actually really a buildup over time. And to your point of the ligament not being ready to sustain a certain amount of stress, usually what we see with the ligament is that when you train right in the off season.
Let me preface that too. I didn't necessarily mean the ligament wasn't ready for the stress. I meant the body itself, like systemically,
sure.
right?
No, completely
chronically,
agree.
it could have been fatigued. It could have been, so some way or another, the recovery process didn't occur enough so that athlete was adequately prepared to then take on the next bout.
Correct. Yep. Totally agree with that. And what I was going to say about the ligament is that when you train them in the off season, right? When you train guys and girls in the off season, we started to see recently that actually low level UCL stress throughout the year is actually a little bit better, we think. So what happens sometimes is over the course of the season, the ligament stretches out a little bit and it gets a little bit thicker. Okay. If you take a few months off from throwing, we think that the ligament starts to stiffen up a little bit and shrink down a little bit, right? Because there's a biological change that happens when something's being stressed. So then if you take, let's say 3 months off from throwing, don't throw at all, and then go back to throwing at a high intensity, your chance is much higher that you're going to potentially injure that ligament because it's not ready to throw. So contrary to what we used to think of saying, okay, you should take 3 or 4 months off, no throwing, you probably should do some low level throwing when you're not playing, right? So this is, don't hear what I'm not saying. I'm not saying you should throw competitively 12 months a year. That's not what I'm saying. But the ligament should see some small amount of stress when you're not competing, just to make sure you don't lose those kind of compensatory adaptive changes that are potentially helpful to the ligament throughout the season. So to your point of training the offseason, super relevant.
Yeah. And I think for us, right, we're very heavy on throwers must throw. Right. And the only way to get true adaptations in such a complex neurodynamic movement is to do it. 100%. You can't be competitive year round. That doesn't make any sense, right? You're just literally stressing the system. Unless it's all an adaptation recovery cycle, right? So the entire thing is like stress, recovery, and then adapt, right? Mm-hmm. And in that time period, understanding how much stress was that? And I think that's the biggest question we have to answer as performance coaches, which is like, how do we value or equate the stress? And I think some of the technology that's out there now claims to do it. But I think it's incredibly unprotected, it's incredibly misinformed. And I think what ends up happening is it creates more problems than good currently, because we've rushed a lot of products to market instead of stringently testing a lot of these products. So, we have a lot of, in-house proprietary ways that we value stress. And we try and look at the entire system, right? So we're going to look at the arm, of course, right? To try and understand, hey, what adaptations occurred? Were they destroyed? And we use certain things to test that. Next, we'll test, on force plates and different ways that we can see power output and, the adjustments to training that need to get taken based off of how this athlete responded to the training stimulus that we just put forth. Alrighty. So, we've discussed a ton, right? And we've unpacked a lot. And basically we're at the point here where we're stating, look, if you throw hard, you're likely at a risk of injury, right? And not owning that is probably your greatest risk. And not fully understanding all the different elements that go into, you making sure you're in the best position. What would you say, whether it's from research, whether it's anecdotal, what do you think is the best advice you can provide for a high school athlete, especially one that now is like improving quite a bit?
I would say part of that is where you and I have to come into play of figuring out what other risk factors are out there that we don't know about yet, right? I think part of what we fall into a trap of is complacency sometimes, where you say, okay, we figured these things out and let's just work with this. The reality is you have to kind of keep pushing the envelope forward and keep discovering things that are out there that we can affect change with. So for me, of what we currently know now, right? If I'm talking to a high school player, if I'm having a conversation with somebody, say, listen, a couple quick things you can do to decrease your injury risk if you throw hard, right? So first, scap control, right? Got to have a good scap program. That's where you guys come in, right? Secondly, shoulder range of motion, hugely important. Internal and external rotation, cross-body adduction, everything. You have to make sure that you're stretching yourself out a couple of times a day, especially when you're in season, because you got to keep your shoulder motion as best you can. Hip motion, super easy thing to work on too. Hip internal rotation, really easy thing. And then there's some things that I think we have on the horizon that I think are still relevant, but aren't out there as much yet, right? So we've talked about this. I think grip strength is really relevant, right? Mm-hmm. I think that if you're looking at things that take stress off of the ligament, right? Those tendons and muscles that help you bring your wrist up and turn your palm down, come off of the inside of the elbow, right where your ligament is. And so if you can increase the amount of muscle bulk and muscle mass and strength that you have in those particular muscles and tendons, you'll take some stress off that ligament because they'll contract as you're throwing and they'll protect the amount of stress that goes to the ligament. So I think that's hugely important. And I think making sure you don't fatigue during a game with those specific muscles is really relevant also.
It's incredible there, right? So essentially you just described hypertrophy and strength in the forearm, right? And
exactly.
Right. So not understanding that strength is unbelievably pivotal in your ability to prevent injury is such a misnomer. It's incredible.
It's properly placed strength.
Yeah.
Right.
Yes.
So it's not like the bodybuilder is not going to be a good pitcher,
sure.
Right.
Sure.
But knowing what needs to be strengthened and what needs to be loosened up, that's why you guys help so many people get better, is because you understand that. And if players can understand what needs to be strong and what needs to be loose, they'll succeed and they'll excel, right? At least in my opinion. And so we'll keep working and we'll keep seeing if we can find other risk factors and things that pop up. And to your point before about the hidden pitches, just keep track of that, right? If you're a high school player, you're a college player, just keep track of how many hidden pitches they're throwing, just in your mind, right? Did you throw 10 warm-up pitches in the bullpen, or did you get dry humped and you were up and down and you aren't counting that as basically getting hot? Because those times when you get hot and don't go in, or throw a bunch of warm-up pitches and only go into the game and throw 5 or 6 pitches, you really got to keep in the back of your head how much workload you're giving yourself. I think that's pretty relevant.
Very cool. Very cool. Well, listen, I thank you so much for taking the time, especially at this hour coming out. And, we look forward to obviously doing some more studies together and then, having you back at some other point and we'll dive into some really deep topic.
Listen, man, I appreciate it. Appreciate you getting me out here and appreciate both of our wives taking care of our kids this morning so that we could do this. Otherwise, to your point before about research, like none of this is possible without like a great team, right? You and I have become a really good team working together. And there's also like the team outside of the team, right? So like for me to be able to do a bunch of research, like my wife puts in a ton of time with our kids. So does yours with your kids. Like, so it's such a team effort that goes into it, similar to sports. So you just carry that forward in life. So all the athletes listening, just make sure you keep doing what you're doing and then it'll set you up for success later in life.
Thank you.